patient video, can the recording be switched off during that period? I will let you know when the patient video is coming up.
I would suggest we don't stop the recording, but what I will do when we upload it is remove that section from the uploading.
That's fine. Yeah.
Okay, wonderful. And yes, thank you, Carl, for starting the recording. Wonderful. Off you go, Abhijit. Thank you.
Thank you, Carl and Riddhi, for inviting me to present here. It is a great opportunity for me and kind of a lifelong follower of Carl's work, although I will say later that basically my mathematical understanding is very limited, but I understand it somewhat different way. So I'm a neurologist. I'm in Preston, and I see a group of patients called Functional Neurological Disorder, on whose topic this is. And I also practice hypnosis, and my plan to establish hypnosis as a formal therapy, which is in a more formal way. So that much ado, starting the presentation. Yeah. So is everyone seeing my screen and my voice is audible?
Yes, we can see your screen and your voice is audible.
Okay, so the topic is that free energy perspective on functional neurological disorder and decoding the core features and proposing some new approach. So the declarations, a few, like I have some grants from Innovative Can PSRC. I'm also founder member of a special intergroup from Clinical Hypnosis FND Society. So I'll be having some aspects of hypnosis covered. And the other main issue is that my mathematical understanding is at A level. I have not progressed beyond that. So there will be some formulae, but if you ask me to go detail about that, I'll draw a blank. And my colleague is there. He is supposed to join. He's in US now. So hopefully he'll be the person who can explain these things better to you. And my approach to mathematics is more kind of visual. I think of kind of a shape, spaces, and other things. But that's how I grab mathematics, and that's how I'll try to go about it. And again, thank you for this opportunity to present here. So this is a culmination of journey. It started when me and my colleague, Dr. Anirban Datta, is at the University of Birmingham. We proposed to organize a workshop on functional neurological disorder and new digital technologies that are coming through to treat this group of patients, and where this journey started. And in that presentation, Quinton present here did a wonderful talk. It is on YouTube videos, and if you want, you can go and look at it on his concept of FNDs and attractor state, and also how hypnosis can go into these other things. And this gave the ball rolling. I also think of similar style. So came this idea how we can kind of expand the context of free energy principles and how we can bring in new therapies. My background in neurology and neurorehabilitation, and I'm a pragmatist. So my main thing is how to get this group of people better, because that's a big problem. Because functional neurological disorder, or FND in short, is common and is a costly neurological condition. So basically, this is a physiological disorder of brain activity emerging from an interplay of intrinsic brain mechanisms and life experience, which causes disability in multiple domains and which is sensitive to psychological and physical factors. It is very common. Actually, 30% of people moving around in different medical subspecialties, we call them the symptoms, who have functional, kind of so-called no structural basis to it. And the second common cause of neurology opinion after headache, at least 60 to 30% of new neurological consultations. In some day in my clinic, general neurology clinic, they're up to 50%. Almost 10 to 12% of all IP admissions, and 8 to 10% of acute stroke cases admitted in stroke wards are due to functional neurological symptoms, usually due to weakness. The cost is extensive. The NHS cost for England, calculated back in 2010, is around 3 billion per year for this unexplained symptoms and other thing. And FND-related costs, now we have more data, 2023, that excess cost varies between 5,000 to 85,000 USD per patient. This USD cost estimate. And there's another paper came out in just recently, showed that the excess costs were more than 2 billion in US alone, both inpatient and outpatient cost. Similar cost we have done our audit, and actually just by attending A&E alone, this group of patients costing a trust around 1 million per year just by attending repeated A&E admissions. Unfortunately, these have been a therapeutic no man's land, which Professor Johnstone summarized very well, that neurologists were not interested in seeing these patients, and the patients were mostly not interested in seeing psychiatrists. So that they fell into this huge, massive gap, the chasm between these two therapeutic domains. And it got reflected in the FND Hope stigma survey that 85% patient told they have just been fobbed off. Nobody wanted to listen to them, and this was the problem. And this is really, FND, I call it the big elephant in the room. Even the elephant is crying for help, but nobody is listening to the elephant. On the other hand, it is true because everyone is seeing the elephant in their own way. Someone is. So this is the great story of 6 blind men went to see an elephant. It is very quite commonly told story in India. And someone saw a spear because they saw the tusk of the elephant. Someone saw a rope because they touched the trunk. Someone saw a snake because it's the tail or something like that. So for FND, because the symptoms are so much multidimensional, they always go to the hospital and come back with a different diagnosis each and point of time. And that's the problem with the elephant. So before I go a bit further, just to go to the history, and it has been known since antiquity. Probably the Egyptians were first to identify this concept. And because they were so common in women, they attributed, and the symptoms were so much variable, they attributed to a wandering uterus traveling through the body. And then Hippocrates get the concept from the Egyptians, gave the first term hysteria, the wandering womb. The Shark was the first to give the concept of functional neurological disorder because he could not find any structural pathology in this group. And he was also the first to use hypnosis, definitively in this group of patients. Then Freud, and then the great divergence in neurology and psychiatry happened, and Freud gave the concept of conversion disorder, and very soon Janet came with the concept of dissociation. Since then, conversion and dissociation, these two concepts have ruled it. And it has changed recently. I'm coming to it. The DSM-4 and then 5 criteria come up, but it is very common. Striking female preponderance, and to 60 to 80%. And the age was seen from 4 years up to 94 years. Population incidence is quite common, as far as, if not more common than epilepsy or MS. And 40% can go into the chronic phase, and the costs are huge. Interestingly, the misdiagnosis of FND has stayed low. It is only 1 to 4%. So if someone has the typical features, the chances of missing FND is very, very low. And this is the current established diagnostic criteria with DSM. And they have ruled out the previous needs of that there should be a psychological stressor has been ruled out, and the onus to rule out that the patient is feigning is not been there. And the symptoms can be many. They can present with seizure-like symptoms. They can present with motor symptoms, either paralysis or tremor, jerks, or any other kind of motor disorder. Functional tics was quite a viral thing during COVID pandemic and spread via TikTok. And then they have functional sensory symptoms, very common in disabling, and functional cognitive disorder. Brain fog is one of them. The other common group are persistent dizziness, MRI negative cauda they come to neurosurgeons, functional speech disorder, and there's strong overlap with long COVID. Now, this is one of the study came in 2021. It showed the symptom map of people with FND. And you can see they never come alone, and they're so common. Fatigue, pain are very common. Although this paper doesn't cover directly pain, but there's 70% had headache. And now currently I have more data on pain, very common, more than 58 to 60% have chronic pain. On the other hand, if you look on the left side of the slide, that the so-called psychiatric symptoms are actually less common. Now coming to the pathophysiology, I'll not go deep into this, so just briefly. Now there is an emerging body of evidence that showed few important networks, including the sensory motor and the temporoparietal TPG network, salience network, limbic network, the attentional network, and cognitive control and motor planning networks are all involved to produce this vast array of symptoms. And there's an abnormality in there, but we are yet to reach a definitive biomarker, but there's work is ongoing. And as such, it overlaps with other chronic conditions like chronic pain and persistent physical symptoms. And the main constructs are disturbance in agency, bodily awareness, interoception, sensory motor function, emotion processing, salience, and all come together in the construct of prediction, and inference. And here comes the seminal paper by Professor Friston, came in 2010, and proposed free energy principles as the main explanation of biological systems and the brain state. Since then, there's an astounding body of work which shows that our brain tries to minimize the free energy or the surprise. And it can do like reducing the prediction errors, and perception optimizes prediction by taking actions. Now then, in 2012 came the seminal paper by Professor Edwards along with Professor Friston, which proposed for the first time an unifying hypothesis how if history, it was a reported history of the, currently we call it functional neurological disorder, is happening. So the main proposal is that because of the coding error, because of the priors, as the priors are changing, the posterior distribution will change. So if someone has a very narrow prior and the posterior distribution, although the prediction is remaining the same, will change depending on where the prior are, and the narrower the prior and the posterior distribution will shift. Similarly, for motor symptoms, the symptom induction at the misattribution will produce and perpetuate some of the motor symptoms. And since then, this is the kind of the current construct with which you work on, and the patients accept it very well when explained properly. Now have a look at the core features of functional neurological disorder. And one of the core features which we always use to diagnose this group of symptoms are distractibility. So when we engage the patient in other motor or cognitive tasks, the abnormal movement disappear. And there is a variability. These two things are hallmark. So the symptoms are variable. Often symptoms emerge when you go and examine the patient. The new symptoms, new tremor come up. And the symptoms emerge, keep on changing through the therapy. Some have seizures, some have motor weakness, speech problem. They come and go. They're variable. And these are the hallmark. And the patients are typical. If you ask them to have good days and bad days, they always agree. And this is one of the hallmark motor sign. I'll show a video later on how we use this sign called the Hoover sign. So look at the on the right side. It is the left leg of the patient. The patient is trying to extend the leg. So when the patient is pushing down, we're trying to pulling it up, and the left leg is weak. Now the patient cannot push down. So we can easily pull up the leg. But when we ask them to move the other leg up, it activates the automatic movement coming from the spine towards the leg, and the leg automatically goes down because of the distraction. And we always show it. And this is a very useful sign to diagnose functional motor symptoms, and this is a very strong sign. Now, similarly, the other signs, the abductor sign, the spinal injury center test, distractibility, everything exists. And there's a huge list of signs in this article. If someone is interested in go and look up this IBEC 2022 article, that all work on the similar principle. So one of the very important signs is this spinal injury center test. The patient cannot move their legs, they're lying in the bed. You just flex the knees up and just talk to them. The knees remain flexed against the gravity, and the patient is distracted. And you tell them at least there is a MRC grade power 3 is necessary to hold the flex. But when you ask them voluntarily to move your leg and other thing, they can do it. This is another very useful sign to diagnose functional weakness when someone is bedbound. And interestingly, this paper again from Mark Edwards and John Stone that showed the signs have remained stable over the centuries. The classical dragging gait sign, the facial dystonia, and the classical arc circle appearance, people having functional seizures, they have remained the same. So the pattern has remained same throughout the centuries. So the pathomechanisms have remained the same. The other typical thing in this group is treatment resistance. And this group, 40%, they don't respond to anything. And unfortunately, two of the major trials, although they could not meet the primary target, specifically CBT could not reduce the seizure frequency, but it improved all other secondary outcomes. So the initial, now the discussion is that possibly the target of seizure number was not the entry. was not an adequate target. It improved other lifestyle-related and outcome-related outcomes, but it failed to reduce the seizure numbers. It was pure psychological. On the other hand, a pure physiotherapy trial, physio for MD, it didn't improve. It is for specialist physiotherapy was not superior to routine physiotherapy for FND. But again, there's a secondary outcomes we measured, it improved, and possibly physiotherapy alone is strong enough. But again, it failed to meet the primary outcome. So there is a gap. There's a group of patients who doesn't respond to psychological therapy or physiological therapy. So what should we do now? And it remains still an enigma. These three things: day-to-day variability, episodic and transient nature of symptoms, and treatment resistance. And one patient wrote to me, and I'm just reading it out. So my name is, I was diagnosed with functional neurological disorder about 2 years ago. At first, the diagnosis felt like a relief. As it finally put a name to symptoms, I would struggle to explain myself and others. But soon I realized that having a label didn't make the daily experience any easier. Each morning begins as an unpredictable mystery. Some days I wake up and feel nearly normal, able to walk smoothly. My limbs responding the way always do. The mornings fill me with cautious optimism, a fragile hope that perhaps the worst is behind me. Inevitably, the symptoms return, and when they do, they come suddenly. I might be in the kitchen preparing breakfast without warning. My legs give away, trembling uncontrollably, refusing to hold my weight. On other days, it's fine. The unpredictability is exhausting. Some days symptoms last only minutes, briefly disrupting my routine before fading away as inexplicably they appeared. On the other days, episode linger. And again, for treatment, yes, tried them all, or at least how it feels. Physical therapy, medications, cognitive behavioral therapy, they each come with promise but deliver inconsistent results. There are moments when therapy seems to help, when I regain strength and confidence, only for the another wave of symptoms to wash over me, resistant to all my efforts. However, I'll be cautious interpreting this as an universal, but this is a group of patients, 30 to 40% are treatment refractory, but for majority, they do quite well. So my main quest was to search for a common solution coming from the theory. Can we explain these things, and can we expand the theory to explain these things better and come up with something else? And here the journey started. This slide was given by Anirban. Hope he'll be joining the discussion from US. And main thing is that perception optimizes the bound, and perception is necessary, but action is optional. So there's a between complexity and accuracy and external state, and this is where we go. Now, for me, what I realized that attractors, specifically these deep attractors, the basin-based attractors, represent their state quite well. And their attractors are, so they move around this brain state, move around these attractors, and they're quite deep compared to the normal. So me and Anirban, we tried to calculate these things, mainly Anirban, and we came to this thing that as we variability shifts in the precision weighting due to stress, pain, and fatigue, the attractor basin becomes very deep, and the sensory versus predictive precision imbalance, and the creation of new pathological attractors due to precision dysregulation. Now, this precision is due to prior belief, stress, pain, other things happening, and the belief system goes haywire. And you can see in this picture, rather than a smooth, normal attractor basin, there is deep, and they're stuck somewhere. And it can also explain this sudden jump, kind of this kind of old theory of this catastrophic transition that in the system potential, and suddenly something jump. They have a sudden transition, and the catastrophic transition and the divergence happens, and the behavior plane they change. And it is very quite common. A group of patients always come up after surgery, after trauma, suddenly something happening. There may not be anything, but there is a sudden onset. Like I have few patients. One patient is so dramatic that he was a British Army veteran, and he went for a colonoscopy. It was a very painful process for him, and his neck was kept twisted in a posture which was again painful. He had previous cervical spondylosis. Since then, he has got functional dystonia. Everything has been done. Now we're treating him. Some improvement is there, but even for him, everyone seen him. He was one person who ran the the marathon des Sables. The 7 day he ran this Sahara Desert, and now completely disabled due to these symptoms, sudden. And there is a group of patients in whom there is a delayed transition. They feel, okay, the acute period of phase when I was difficult and they're over. And it often happens that patient in the holidays, the symptoms start there. Maybe delayed transition due to Hoffman bifurcation that is happening later. The critical period has done and it is expressing itself later. We don't know. But thinking like this visually, they give me, I think this is something happening like them. And maybe in few, and this is where I need your help to understand if it's something formula we can come up or we can do. Now, these maladaptive attractors, they're characteristic by this deep free energy basins, and there's a high barrier and low probability of spontaneous escape. So when they get there, they get stuck, like a deep basin, it is stuck, and persistent and treatment-resistant symptoms. On the other hand, when they're in the boundary of it, they move in and out. That's why there is the variability, in and out, not stuck, coming and going, not stuck, coming and going. And while I was working on this presentation, I just recently came up with this paper published in 2022. I didn't have much time to go through it or understand it. But again, if I think kind of overall, this also explains a lot of things for the Rene divergence, because it's a kind of generic group where the KL divergence is one part of the Rene divergence, how I understand it. And there this alpha state changing, the mass covering versus mass seeking, then they explain these things quite well. And I feel this can be another explanation of this thing. Now, what I'm interested in this to do, because there are two things we can correct: the internal generative model parameters and the sensory evidence precision. So my hope is that if we combine them together, which we usually do not do in a single session or something like that, then possibly we may lower the energy barrier and facilitating escape from this pathological attractor state. So this is my hope and this is my understanding, and where if we can do something combination way and some breakthrough, some mathematical modeling and something to understand, it will be very helpful for this, because at this moment, physiotherapists and psychologists don't work together. Now, to bypass these things, so I have a new kind of convert to hypnosis. Before 2022, I was kind of a skeptic about hypnosis, but this is kind of my main modality of treatment with people with functional neurological disorder. Quinton is there in the presentation as an authority in this field. So hypnosis is a process in which one person gives a suggestion to another person for imaginative experiences involving alterations in perception, memory, or action, usually after an initial set of suggestion for the subject to enter a hypnotic state or induction. So after we induce them to, and all hypnosis is known as called self-hypnosis. If someone is not willing, usually it is not impossible to hypnotize he or she. Now Charcot again was a forefather, and he had ran his use hypnosis to induce, and in somewhat a very pathetic way, using kind of the age of male chauvinism, demonstrating women patient with FND and leading his clinics where the people used to go into hysteric posturing and other thing, and they used to fundraise. So this is a black period of neurology, but he was the first person to use, induce, and treat functional neurological disorder with hypnosis. Now there are mainly three. The construct of hypnosis is very complex. Even I do not get it, and there are there's a contradicting concepts and ideas, but the main concept is that the three things happen: absorption, dissociation, and suggestibility. So the person becomes fully involved in a perceptual, imaginative, or additional experience, then they dissociate from the components of experience, and they're open to suggestions, what being taught to them. This is the main three things happen. Now, if you're interested, you can read Quinton's paper published back in 2016, Why Hypnosis is Very Good for Therapy in Functional Neurological Disorder. But we have found, but people have shown that, like Devintar, another person working in this field, that people with functional neurological disorder, they're highly suggestible. around 85% people with FND are highly suggestible. On the other hand, the suggestibility in people with general population is around 15%, so almost 6 times higher. Whether this is a cause or effect, we do not know. And there's a long existing study that's shown that people with functional neurological disorder, when they try to move a leg, the activation pattern, on the other hand, the people with cerebral palsy, so the attempted movement of the hypnotically paralyzed left leg are the same. So hypnosis mimics the functional neurological disorder pattern. And what we know so far about hypnosis is this: the 3 stages, that subject relax and focus, there's reduced activity in dorsal anterior cingulate, and there's a decreased connectivity between dorsolateral PFC and default mode network. The brain is more receptive to suggestion, and increased connectivity between DLPFC and insula. The brain puts the suggestion to work. It is a very simplistic way to put it forward, but it is not like that. I'm just using it for my own. On the other hand, if you look carefully, the hypnosis actually opposes the changes that are seen in functional neurological disorder. This is something we're working now, and hopefully it will be out as a paper soon, but there's a massive work going on. So again, I borrowed from Friston's paper, and they proposed it for psychedelics. And I think hypnosis works in the same direction, because these groups, now we call them non-ordinary states of consciousness. Psychedelic hypnosis, they're somewhat similar, but if you look carefully, the brain network activation is different. The experiences are different. They start at the same point, but they're different. But it possibly works in a similar way. It just relaxes beliefs, either under hypnosis or psychedelics. So I repurposed the term rebus to riba, doing the same things. And now we have the great, our recent review paper published last year, where we showed that hypnosis is very effective and is around 25% effective, when there are other case reports from UK that shows the similar thing. One interesting thing that the study has shown that possibly the non-hypnotic suggestions are also equally effective. So possibly it is the suggestion which is doing the main work. And I have given the link for Quinton's talk in Royal Society, and where he has dealt in detail in mechanistic way how. So interested, you can listen to it. But what I have tried to do, because of my concept of top-down and bottom-up, because of my neuro rehab background, try to use hypnosis with something else. So this is one example I'll show. So this lady, she presented 2 years history of weakness in the right leg and chronic pain. So what I will do, I will first induce the weakness, and I'll demonstrate the Hoover sign to her. And I'll tell her how this is a kind of a trick that the brain is making to her. Then that part is not shown here. I will use a brief hypnotic session. And I'm collecting my own data, and she's one of the patients, around 11 out of 37 patients who improve very quickly. 28%. They improve very quickly with a single session. Not everyone improves that quickly. There are other groups that improve. The overall improvement, again, for me, is between 60 to 70% after a brief session. But there's one group, they have a sudden, dramatic improvement. Possibly the phase transition that we see in FND is again working here. They're improving in an opposite direction. Just look at it. So pushing a right leg down, but the leg is weak. I can lift it up. When I lift it up, the leg is jerking because of the variability in her symptoms. I'm pushing her left leg up. The weakness disappears in the right leg. The right leg becomes stronger. This is a hallmark of Hoover sign. Now, after the hypnosis, and this is after hypnosis, we focused on her pain and other things. So she gave a nice picture. So she could use an imagery. There's a pincer is coming, grabbing her spine, making her leg weak. I give her hypnotic suggestion and metaphor just to lose the pain, make the pincer loose. And she thought, oh, wow, that's fine. My pain is gone. And next it happens this. Leg has become stronger. She couldn't lift it in the past. The tremor is gone. And she's one of the patient who is asymptomatic now. I've discharged her. She gave a very glowing review to our survey letter. So another patient was there, some challenging, but again, coming with variable symptoms. This patient, we used pharmacosuggestion. The old name was narcosuggestion. I don't like it. So this is a lady coming with refractory pain, fibromyalgia, started again after fall from bed, having back spasms since then. She's known in our trust by almost everyone. A&E, she comes back to A&E multiple times in a month. And she has vigorous whole body spasms. And she has tried everything. I tried hypnosis. She could not undergo hypnosis. She could not be induced because the symptoms are so severe. So I used ketamine in her. Ketamine has been approved in our trust for refractory pain. So it gives me a leeway to try it under her. And I tried when she was under ketamine. I tried giving her suggestions. The one interesting thing, I have an explanation. Unfortunately, I don't have the video. She was knocked off under ketamine. Under anesthetic agent, the spasms were ongoing. So I reduced her ketamine level, and when she could listen to her, I gave her suggestions. The suggestions was that the waves are coming, and she gave me, discussed in the past, she loves to sail, another thing. I have a suggestion to sail over those waves, and slowly she got it. And she returned back, she gave me vivid description what happened, like going through colorful tunnels, riding the waves. Since then, the spasm disappeared. She was discharged after 48 hours, but came back with other symptoms. And the symptoms have evolved now. Now she's coming back with seizures. And she developed weakness, recovered, and she is the symptoms for which she came, the spasms, they've improved. But I think we need some more work with her and still not recovered completely. Now, using traditionally in the current practice of hypnosis, we're not supposed to touch our patients. One person was but when they started, it was James Esdale. He was a surgeon in Bengal, the place where I come from, and I didn't know it. And he had his own mesmeric hospital in my hometown of Calcutta, where he used hypnosis to operate on patients, and very well documented. And it is very well documented. And after then the anesthesia came and the hospital was shut down. He used to use a technique by stroking people and putting them into deepest trance state. And he learned it from the traditional fakirs of India, and he called it Jharfunk, the term used by the fakirs. There's a lot of literature on this. But yes, Hypnosis Plus has been used in the past. So I'm nearing my end, 3 minutes left. So times of the future direction. So, and I'm a kind of William James follower, and I'm kind of pragmatist. So I feel that truth in our ideas means their power to work. And so I want these concepts to put work for my patients. The main advantage will be changing the current therapeutic dogma. If we have a good paper and kind of coming out, I'm very happy to work with, if provide me this mathematical other support, it will change the therapeutic dogma. And we can do some neuroimaging of hypnosis. We're collecting some of the patient's data pre and post, and we can collect some multimodal data, autonomic, psychological, immune stress biomarkers. We can work with maybe UK Biobank and collect the data, and that's it. We can go ahead. And I'll be happy to stop here, share. This is my childhood place, yes, Darjeeling, and this green things you see at tea bushes, the famous Darjeeling tea. Thank you.
Wonderful. Thank you so, so much. Can I please invite everyone to unmute and turn on your cameras to give Abhijit the big round of applause. Thank you so much. That was a very, very interesting presentation.
Excellent. Thank you.
And very important one as well. It seems to be very important in terms of our understanding of treatments, and especially with your case study that you presented as well, which honestly, congratulations on that as well.
Thank you.
Yeah. May I please invite any questions that people may have or discussion points that they would like to raise with Abhijit? Please just feel free to unmute or use the raise hand function. I'll call upon you. Oh, Do we have any questions? Yes, Quentin.
Well, thank you very much, Abhijit. I think it's I suppose one of the questions which your talk raises, Abhijit, and this is a good forum in which to explore this, is how to conceptualize the relationship between priors as articulated in hierarchical predictive coding and attractor dynamics. So the Mark Edwards paper from 2012 is a very impressive exposition of the application of hierarchical predictive coding to understanding functional neurological symptoms. And one of the implications of that paper is the emphasis upon mid-level cortical regions in the control hierarchy of cognition or behavior, the functioning of which is modified to generate a change in experience or motor function. So, for example, you might have altered activation of insula to generate a functional symptom of pain, alteration of somatosensory cortex involved in generating a sensory alteration, a sensory loss or a paresthesia, or alteration of supplementary motor area activity to generate either a paralysis or an involuntary movement. And the idea is that there is misdirected attention producing abnormal gain of a altered prior, which is relevant to the symptom in question. And that perspective, I think, has great value in a number of respects. I think one idea is that it provides insight into the specificity of symptoms because it's identifying association cortices which are known to be involved in relevant symptom domains. The symptom domains of functional symptoms are extremely heterogeneous. They're very varied clinically. And the functional neuroimaging research to date has shown that the functional correlates of different types of functional symptom involve cortical regions that you would expect to be involved in those types of symptoms. So there's a good fit from that point of view. One of the questions I think that arises from that type of perspective is how can we develop a better understanding of the broader cortical landscape within which these specific mid-level changes in cortical regions occurs to generate a congruent symptom. And so it raises a number of questions. One, to what extent can we think of as being a hierarchical organization of priors, for example, which constrain information processing, and how are they implemented or represented within the brain? And going back to this point that Abhijit, that you're emphasizing, is the persistence of functional symptoms, that they are very difficult to modify. They become very entrenched. It does suggest that we need to have a conceptual framework which can capture over-consolidated learning within distributed brain systems, within which critical nodes alter function under relevant stimulus conditions, which represent the maintenance of the functional symptom. Functional symptoms are somewhat variable. Many are episodic in character. They arise in response to particular cues, self-generated cues or environmental cues. So, for example, non-epileptic seizures would be an episodic functional symptom. They're not, one isn't having a seizure all of the time. It's episodic, it arises under certain conditions. But even motor symptoms wax and wane, and they, as Abhijit illustrated, they manifest themselves when task demands are placed on the individual to produce the movement in question. So there are relevant cues which activate schemata, which generate the symptoms. So just as a final point, actually, before sort of inviting comment on this, Abhijit makes the interesting point about suggestions in hypnosis as potentially modifying functional symptoms, which is indeed the case. There is a very close conceptual relationship between suggested effects in hypnosis and functional symptoms. That is to say, every single functional symptom that exists can be reproduced with a suggestion. But there is a difference as well, an important difference worth reflecting upon. When we make a suggestion in hypnosis, if we think about it in a hierarchical predictive coding framework, we can think of it as the introduction of a high-level prior, which as part of a reversible cognitive set, which reorganizes cognition to enlist association cortices to generate a symptom which is congruent with the content of the suggestion. In the case of functional symptoms, whilst we may conceptualize functional symptoms as operating via priors, they're not reversible, or they're not readily reversible. They are overlearned. They're more automatic. They're less consciously accessible. So we should not assume that the high-level mechanisms of suggestions and functional symptoms are identical. But they may, because there's an automaticity and an conscious inaccessibility to functional symptoms, which is greater than that of suggestions, because when you administer suggestion, you're typically conscious of the content of the suggestion. You engage with it attentionally, and then it exerts its effect through processes which aren't introspectable, but we're aware of the high-level content of it. So the broad question which I'm asking is, how can we qualify and extend the notion of priors by considering how they're more from a diachronic or temporal extended perspective, to see how they're implemented within learning or over consolidated learning. Most likely, actually, in the case of these complex symptoms, like functional symptoms, within non-canonical networks, highly distributed across high-level transmodal association cortices.
No, should I take a go? Yeah. No, I think, Quinton, you have summarized possibly much better than me what I tried to tell. And in last few minutes, no, this is something I understand remains the key. The network we have identified are vast. Again, if you look at the network, possibly the insula and other part, they play a role because of their associative action. There's the associative cortices, they may play a role. And again, involvement of the learning curve, the learning pathway, because they're the part of the distributed learning system. But again comes, which one is first and happening what next? And the more the symptoms happen, the reinforced learning happens. So which one is making it perpetuated? But we know from the literature and from experience, again, one patient improves suddenly. So what happened to their priors? And I think the latest 2022 Rennie paper, where they produced this alpha, this mode seeking and other approach, if someone can explain it better than me in this group, possibly that will address some of the questions that Quinton has raised. That paper is, I know what this paper is trying to tell, but I cannot explain it properly. The Rainy 2022 Fristen's Carl's paper. So that aspect where they approach in a different way possibly has some of the Quinton's concept. But again, what I feel this insula and the cingulate cortex, they play a role, because if we look at the literature, again, hypnosis, specifically from the pain, which is a strong risk factor for FND and other thing, this is the network, kind of the triple network disease, where this is the area which is activated and deactivated with hypnosis has the most action. So possibly they are playing a role. Again, whether the prior comes, the prior stays the same, or the prior changes over the time as the patient's symptoms evolve, some new things happen, new life paradigm evolves. We do not know, but this opens up a possibility of kind of empirically studying it. And I think if we look at the symptom variability, which group of symptoms happening, which group of symptoms are refractory, we can get some answer from here to collect a data set like which symptoms are more commonly we can treat with this group of symptoms and the others are not. I'll just give one more example. Recently, I saw one of a consultant colleague came up with sudden bodily symptoms, nothing else, no psychological history, nothing, but he has nothing. There's some fluctuating sensations in his one side of body. I did the MRI is nothing. And then I sat with my neuro consultant colleague. There is a very tiny change, possibly some capillary malformation deep in the right temporoparietal junction. It will possibly not require any intervention or anything. We're keeping an eye on it. But for me, that vessel change possibly has disrupted his interoception and other sensory feedback. That is why having those symptoms. We do not know. And I think Tim Nicholson, their group is working on some collecting data. And I have seen in many people. So again, FND is common in people with migraine. And in migraine, actually, if we do MRI brain, they have a lot of small vessel changes. Possibly some of these changes is going on, working with these distributed networks, producing disruption, causing these symptoms. So I do not know. And in this group of patients, what is prior? So again, bottom up, top down, what is the prior? Another thing, I think the kind of circular questions, the more you collect the data, we'll know.
So just to follow up on that, what kind of data would you be looking to collect in order to decipher whether it's bottom up or top down?
Yeah, again, what is bottom up? What is top down? It's a circular question. So far we know the psychological aspects, we call it top down. But there's enough evidence, even with, and people know psoriasis, another thing, the stress and everything, flares of psoriasis. So what is bottom up and what is top down? Sometimes very difficult to say. The physiotherapy is considered to be bottom up, but we have seen some physiotherapists are very successful with FND patients, how they talk with their patients. So, and some physiotherapists are not. When the patients don't go to work with them, how they communicate with them. So very difficult to differentiate between what is pure bottom up or pure top down.
So then what kind of data are you referring to in order to
the kind
collect?
of data we are currently we can collect. I'm doing some collecting some data on hypnosis, what happens during hypnosis. We're collecting the whole brain FNIRS. We've collected few data sets. I wish Anirban was here. And the whole brain FNIRS, very few data set, and planning to get some data, what happens real time when someone is undergoing hypnosis. We can see that. And because this is FNIRS based data, so we can do it real time. The patient can undergo hypnosis and we can see the changes. So this is something me and my colleague are trying to do, but again, but I think I have not answered Quinton's questions, which I think the question is still open. I just provided some directions.
Would you like to respond, Quentin, or anybody else? Yep, Quentin.
Yeah, just on the question of top down and bottom up. So I think, I mean, I think if we articulate that in sort of cognitive neuroscience terms, then obviously we'd be conceptualizing that in terms of the cortical hierarchy, and in terms of information which is perhaps coming on the bottom-up centrifugal direction using Messelam's distinction, and then top-down in the centripetal direction. So with respect to the type of questions that arise in functional symptoms, we might have a rehabilitative intervention which illustrates to a person that actually they have a retained ability to walk. So for example, one of the techniques that's sometimes used with people with gait abnormality is that they have a very prominent gait abnormality walking forwards. But then if you ask them to walk backwards, they walk backwards normally. So that is important because it illustrates to them that their basic motor physiology is intact. And so there is an abnormal learning of sorts, and I'm calling it learning in inverted commas because I'm interested in how best to characterize that altered, consolidated abnormal functioning. So the behavioral experiment can illustrate intact motor physiology, but the symptoms nevertheless remanifest themselves despite the illustration of intact motor physiology. It might be over many successive training sessions with a physiotherapist or a neurorehabilitation person that they can start to relearn that they can move normally. Similarly, with suggestion in hypnosis, that would typically be considered a top-down intervention because you're effectively introducing ideas and imagery within the content of the suggestion, which presupposes high-level cognition in order to be able to understand it and engage with it, sort of linguistic processing, the exercise of imagination, comprehension, and so on. And it is by virtue of representing that information that a suite of changes is enacted across the cortical hierarchy, which produces a downstream effect, an alteration in sensation or an alteration in movement. But even with the administration of a suggestion, as Abhijit was saying, through that top-down direction, again, the relief may be only temporary. So there's something very important to understand here, where I do think the attractor dynamic language is useful, the sort of conceptual framework is useful. And I'm interested to hear what you think about how you would conceptualize this from a hierarchical predictive coding framework. Is that there is an overlearned or over-consolidated distributed set point within cognitive systems to which the person returns. And for therapy to work, it requires relearning, learning a different new way of functioning normally, or modifying existing motor schemata or sensory schemata which are dysfunctional. And so I think that that sort of temporal or diachronic learning perspective is actually very important in all types of psychopathology and indeed all types of pathology. Whereas when I read about hierarchical predictive coding, my understanding of it, which, within the limitations of that understanding, is that it tends to, I think, give examples which tend to operate over relatively short time periods. There is belief updating, but there's an important question here, is how does that belief updating embedded within the life history of an individual where events may be constraining cortical organization, which happened years ago, which then produce, again, using that attractor language, produce a different attractor landscape, which the system falls back into. So I think, so that's one question that arises for me, and also thinking as well, because the symptoms that we're describing, functional symptoms, involve changes, as I've said, within critical points in the processing hierarchy, which are not normally consciously accessible. Although their outputs are delivered to consciousness, they don't fall within the realm of normal voluntary control or conscious awareness. So, somatosensory cortex, insula, and so on. So these key changes are occurring there. And of course, these systems can be modulated by exteroception or interoception, or indeed by higher order influences coming down. So bottom up input or top down input. And in terms of the rehabilitative interventions, the treatment interventions for FND, as stated, both can be enlisted. So bottom up inputs can be enlisted through movement or altering sensory input, or indeed these high level processes can be engaged through psychological treatment or through the use of suggestion. So yeah, I mean, I think that's, so in a way, actually, in order to understand these symptoms, we actually need a good understanding of the entire cortical hierarchy, from the sensory interface, the sort of coniocortical interface and motor output, primary motor cortex, right up to the highest levels of cortical organization, the limbic regions, and these non-canonical networks, default mode network, and higher executive multiple demand network, and so on, as they're conceptualized now.
Sorry, is there a question in that, or is it more?
Well, it's a reflection, but actually,
yeah.
I suppose the question, it's a reflection, but there is a question actually. It's how do we conceptualize priors as they're set out within hierarchical predictive coding within a developmental or temporally extended time frame, and how do we understood priors as certainly high level priors as represented in distributed brain systems such as default mode network, multiple demand network, or however else we might conceptualize non-canonical networks, which are fundamental to constraining the regulation of cognition and behavior.
Does anyone want to have a go at responding to that? Or have any thoughts about it? No? Okay. Just some.
As a this has been a comment here. Sorry. As a physical therapist, first of all, I thought your presentation was great and very informative. And as I'm thinking through this, I've always been interested in the top-down approach as a physical therapist. And I shouldn't call it an approach, because what I'm recognizing in this conversation here is that is there really in this context a top-down and bottom-up distinction? So, for example, I love how you talked about hypnosis plus touch. So the framework, it kind of makes sense that, okay, well, the hypnosis is a top-down because we're working on suggestions and expectations, I would say, beliefs. On the other hand, if I'm going to introduce therapeutic touch, is that not just another way in to the suggestibility. So is it a suggestive touch? And I don't know if I'm being helpful by introducing this, because it doesn't create it as clear a picture or as neat a picture of suggesting, okay, this is top down, this is bottom up. I think it's certainly both, maybe outside in, inside out, which would probably have its own problems, but I think we're probably working on the same, I guess you could almost say, direction, if it's a suggestive touch, or if it's a suggestion that is more linguistic. Going to on this, I think either way, if we change the suggestibility, we're probably also having a bottom-up effect simply by increasing the precision weighting of those bottom-up signals. I don't know if I've done anything but create less clarity, but I just thought that was interesting, the way the dialogue evolved. It made me to think about these things in a new way.
I agree. It's always going to be both, we're the symbolic species, and we can't help but interpret what's going on with it, even if an intervention is apparently purely sensory or motor. It's equally something that we're aware of and are interpreting. So it's always both, but in the situation of somebody, for example, to whom is a person who is still, to whom one is introducing a suggestion, I think we can reasonably say that the primary processes cognitively which engaged are those of high-level cortical function, high-level cognition, and the effects, to the extent that they modify sensational motor function, are transmitted in a sensory petal top-down direction, as it were, recognizing the reciprocal nature of those influences across the hierarchy. And equally, the physiotherapist doing physical interventions with movement and sensation and so on, there's a significant sensory motor component to that, but equally that will simultaneously be interpreted, which enlists additional processes and effects, as you say.
Stephen?
Thank you. Abhijit, I applaud your presentation and your intention to help your patients. Whatever works, in my opinion, is what's most helpful. I'll just relate a couple of experiences that I think are relevant. Something Mark brought up is related to experience I've had working with PTSD patients in the Veterans Administration, applying insight meditation practices to help them with their trauma. It's very difficult. They're hypervigilant, and being quiet and accepting tends to trigger their trauma, but having someone standing behind them with a hand on their shoulder, someone they trust, with a hand on their shoulder, seems to allow them to go through the process successfully. So I'll just give that. And I'm oriented towards the competition in a person's mind between in the moment sensory experiences and the pre-existing biases, or I guess you'd say priors. And I recall hearing presentations on the role of the thalamus in shifting the balance towards the moment-to-moment sensory experiences, interrupting the predictive processes. And the relevance of that to the insight meditation process of being very quiet, calm, non-moving, and focusing on the moment-to-moment sensory experiences, while I would interpret it as reframing occurs. So just leave it at that.
Yes, Abhijit. Abhijit, you're muted.
No, thank you, Stephen. I think this was a wonderful feedback. I was not aware of this thing. But I can give one corollary from neurology we see in a group of people what we call dystonia. So dystonia is a motor disorder. It is a kind of a very well-known condition, but there is no structural pathophysiology. A lot of study, and again, it's a combination of cortical and subcortical, thalamocortical dimensional change in people with dystonia. So there's a persistent abnormal movement. So the group of people with cervical dystonia, they manifest a unique thing. We call it sensory trick. So there's a part of the face or the other part of the head. If they touch momentarily, dystonia disappears. It is very well-known phenomena, not yet, mechanism is not yet known. There are certain hypotheses, but we really do not know why it happens. Possibly this concept, there's a competition between two things going on, and the touch input, it supersedes. Is and it takes precedence. The moment the touch is gone, dystonia comes back, and dystonia is persistent. And the main treatment is bottom up. We use botulinum toxin to weaken the muscle. There's one patient now, which I'm treating. I talked about him, his symptoms we started. I'm treating, it is one patient, I'm treating a functional dystonia. I'm treating with a combination of hypnosis and botulinum toxin injection. Previously, he failed botulinum toxin. I'm treating him with suggestion and botulinum toxin. I have some of his video, but not today. I can show it some other day. So his head movements, the dystonic neck posturing, corrects under hypnosis, but it comes back when the hypnosis is over. So I'm combining with the hypnosis and botulinum toxin to see how it works. If it works, we'll publish it. So yeah, so these are the complex things. What is top down, what bottom up, what is a prior? We need further clearer understanding. Only then we can walk through. And this is what the question. I think we are in a very exciting area in this thing. And there's a group of therapies, and actually in hypnosis also we go through induction and we ask them to focus on. So hypnosis, you use a thing called VACOG. So visual, auditory, kinesthetic, sensory, gustatory feelings. We ask them, we can induce these physical sensations in people and we can ask to focus on them. And this is often very effective as a distraction tool. We can ask them to visualize a colorful ball and focus on the color, or ask them one hand is lighter than the other and focus on that lightness. And this is a very well-known thing, that hand will feel the lighter will go up. It's one of the very strong hypnosis induction technique. And those are the kind of things. So yeah, but thank you for the concept. It will be useful for me, the competition thing. Yeah.
Quentin?
You're muted, Quentin.
Yeah, Stephen, you made an interesting comment there about competition during the example you cited. I think of people combining insight meditation who had PTSD. So that, I think, is where competitive interactions between networks fit in to understanding priors and hierarchical predictive coding, I think, is also very interesting question, because it goes back to this point that we were making earlier. Abhijit also mentioned this as well, and I commented on it, as to the contextual or cue-driven or contextually driven nature of the elicitation of functional symptoms. And what this suggests is that under certain circumstances, abnormal priors or representations, as it were, are activated or they're enlisted and then influence cognition. So the idea that there can be a cue-driven nature which elicits priors and makes them contextually relevant is very interesting, because it raises the question, how are the priors implemented, represented in the brain across different cortical networks, and what are the processes by which the constraints by which if you like, an abnormal prior can become active and causally influential, and are those processes best understood in competitive terms, in terms of different input conditions or cues, such that one representation is activated in preference to another because its input conditions are met. So again, it goes back to this question, is how do we conceptualize the prior operating across the cortical hierarchy, not understood acontextually, as it were, but is embedded within the brain, embedded within cognition, embedded within the life course of an individual interacting in a particular context in concrete circumstances. What are those constraints? How do we conceptualize them?
Andrew.
Hello. Thank you, Abhijit. It's really interesting, and I'm finding Quinton's questions and comments absolutely fascinating. It seems to me that as a therapist or physiotherapist, at times I'm introducing a different model, whether that is a prior or whatever it might be, through my interventions, and it's almost a competing model of what the world is like. And just an observation here that if we have a couple of attractors, a couple of models where people can switch between one and the other, one of the really important things as a therapist is to say that, to be honest, and say you may revert to the previous model. It may be when you go into a particular set of circumstances. It may be when you've had some alcohol which kills off a new circuit, whatever it might be. But I think we should be honest that because, as Stephen says, trust is really important here, and anything that may undermine the new model, the new prior, is something to be avoided. If that person, as Quinton says, needs to relearn over a period of time the new way of thinking about the world, whether it's feeling about the world or thinking about the world, whether it's bottom up or top down, either way, there may be two different models, and it's really important that we don't say things that may then be contradicted by people's sensory input and by their experience.
Yeah, that's absolutely right, Andrew. Thank you. I think this would be a good spot for Carl to provide a summary and some feedback if he's ready. So I'm going to call upon him.
Yes, you can call upon me. I'm
Yes.
never ready, but I'm here.
Thanks, Carl.
Yeah, wonderful presentation and particularly wonderful discussion. So there's not much left for me to say, which is, I think, probably a good thing in this instance. But just before I forget, just to pick up on that last exchange, in answer to Quinton's notion, is there some kind of competition going on? Absolutely. The the free energy principle is just how we select our generative models of the world in which we find ourselves. That selection amongst a number of alternatives, and Andrew was describing at least 2 alternatives or hypotheses, is just the process of modeling your world and selecting the right hypothesis. So in a sense, we are, as scientists, this is what we do all the time. We have an alternate hypothesis and a null hypothesis, and we adjudicate the evidence for these 2, and we alight on one hypothesis or another one in the face of the evidence. So I guess the question is, how can that go wrong? And it can go wrong very easily if you assign too much weight to one kind of evidence relative to another kind of evidence. And the weight that you assign mathematically is the, if you're a statistician, it will be the standard error associated with some estimators, or the noisiness, signal to noise in the data. Most generally, though, it is the precision that you afford this kind of evidence relative to that kind of evidence, relative to your prior beliefs. And if you get the balance of the precisions wrong, you will make false inferences, and there can be of the sort of type 1 or type 2. You can infer something is not there when it is, or something is there when it's not. And that sort of generic failure of inference, I think, nicely accommodates the diversity of functional neurological symptoms. So whether we're talking about hypothesia or paralysis, or indeed in a psychiatric context, neglect syndromes, dissociative syndromes versus productive type 1 errors, hallucinations and delusions. So this notion of selection based upon the precision that you afford various sources of evidence, usually from your body, I think it is absolutely central to the arguments and the sort of the mental models or the narrative accounts that people have been articulating from different perspectives. Just as an aside, it's nice to meet you, Abhijit. I think I was a reviewer for your Royal Society proposal many years ago, so I'm very glad that got through. And I assume it was an excellent event, and lots of friends were made. In terms of summarising from the purely theoretical perspective of the free energy principle and active inference, I have, as usual, sort of identified a couple of papers, some of which have already been mentioned, but some may provide useful perspectives or points of contact that speak to some of the issues you've been talking about. The common thread, though, is really this focus on precision. So I'm going to give you a stream of consciousness now, which developed during listening to the presentation and the subsequent discussion, which tries to pick out the commonalities that would ultimately speak to not just a story that one can share with one's clients and patients, but also might underwrite a neuroimaging approach to this that tries to sort of, I repeat, sort of speak to the common themes. So if I can share my screen, which I can hopefully. So hopefully you're seeing this. So just to rehearse or show again a graphic during the presentation, just to emphasize the importance of different hypotheses or different explanations that anybody would bring to the table to explain their current sensations and embodied responses to the sensations. I'm putting this figure up from Robin Carhart-Harris's rebus hypothesis, and just making the point again that sometimes, and Quintin was expressed this about on 4 different occasions using slightly different words. The point being made, I think, was that people get overly trained, they get entrenched in particularly precisely held beliefs that in this picture, if you want to take a dynamical systems perspective and imagine that your state of mind is a trajectory on some Waddington landscape, which in this instance happens to be the free energy landscape, if you get trapped in one particular hypothesis or explanation relative to other alternative hypotheses or explanations, then the deeper or the higher the curvature or the sharpness of these minima, the more likely you are to remain there and get stuck there, unless something happens like a phase transition of the kind that was mentioned in terms of bifurcations or Hopf bifurcations. The mathematically, that I think that's a really interesting observation. This notion, I repeat, of being stuck in a particular minima, ravine, or canal on these free energy or Waddington landscapes speaks immediately to the importance of precision in the following sense, that the precision scores the curvature. So mathematically, if you imagine this shape here being mapped to a corresponding probability distribution, you actually take the negative of it and then take an exponential function. So things that have very, very sharp minima map to things that have a very narrow zone of plausibility, a very high precision. Whereas if your landscape is much flatter and has a higher temperature, for example, that corresponds to a probability distribution over your hypotheses that is much broader, more dispersed, has a higher variance and a much lower precision. So you have to get the precision right in order to enable the testing of different hypotheses by jumping from one minima to another minima, should the evidence suggest that that is the right thing to do. And that notion has been pursued by Robin in terms of the notion of canalization. So I'm coming back to Quintin's sort of account of how do we get into these ruts? How do we get into these overly precise commitments or convictions to this is how my body works and this is how the world I work in this world? And I think one compelling notion here is this notion of canalization, very much in the spirit that a river carves its own riverbed. As it gets deeper and deeper and deeper, it is much more difficult for the river to escape its particular riverbed. And that, again, speaks to the precision of the landscape that is being, I'd rather hoped, I'm going to have to search for it explicitly. So here's Robin's picture of a landscape that again is self-carving, it's self-assembling, and sometimes you can get stuck in one or other of these canals where things become inappropriately canalized through a failure to relax the precision of this landscape. And that precision has to be estimated. I just put this up for fun. Everybody says they're not mathematicians. If you were a mathematician, then this precision is absolutely crucial in defining the space of your beliefs or the way that you measure the world. And this is an entertaining but completely impenetrable treatment of the brain in terms of gauge theory. But the key point at the end of this analysis, which I repeat is even for me completely impenetrable, is that at the end of the day, the thing that determines the very distances, the metric structure of our belief spaces is precision that can be read psychologically as attention. So that one could, if one wanted to describe functional FND in terms of an aberrant inference predicated on aberrant precision, what you're saying is this is a very, very complicated, sophisticated form of attentional disorder. And that's, I think, a useful perspective because, of course, that now brings you to, well, what kinds of therapeutic interventions would be appropriate for anybody with a particular attentional disorder. And of course, we're now talking about hypnosis, we're talking about meditative practices, all of those kinds of interventions that allow somebody now to become skilled at deploying their attention or their precision. I think, again, Quentin was talked on a number of occasions about sort of the importance of being able to get some volitional control over, sometimes cast in terms of being able to mentalize what are usually subpersonal processes of this, that have this attentional-like aspect, attending to this or attending to that. And what I want to come to later is the complement of attention, which is the attenuation or the sensory attenuation. These are subpersonal mechanisms that reflect the deployment of precision once it has been estimated, either by augmenting the precision of certain beliefs or sensory evidence, so that they become dominant now in terms of moving you from one model or hypothesis to another hypothesis, or more commonly, the ability, the attenuation of the precision of certain sources of evidence that enable you to functionally ignore. And any failure of that, can have a profound effect, not only on whether you can, whether the sensations that you are failing to attenuate because you now have not been able to reduce the precision, enter belief updating, enter CNS, and enter perception, either personally or subpersonally, or the consequences of that for action in terms of a failure to attenuate. A failure of sensory attenuation will often lead to a failure of action and a paralysis, very much like, say, Parkinson's disease could be construed as a failure to ignore evidence that you haven't actually started an intended movement, and can all be reduced to this notion of precision in Parkinson's disease, as implemented, say, by failure of precision control as mediated or mediated by dopaminergic discharges. Anyway, that's just a mathematical thing. The other, again, this is just entertainment. It is interesting to note that. Well, perhaps we should just come back to a sort of broader perspective. I'm now coming to this notion of understanding hierarchical message passing and belief updating in the brain, and what implications that has for functional anatomy and functional brain architectures. And clearly, all the evidence, including that brought to the table by Mark Edwards' early synthesis, depends upon a hierarchical generative model. And we've been talking a lot about sort of the various cortical, subcortical hierarchies entailed by that kind of deep model or hierarchical model. But there's another kind of factorization or structure which I think sits on top of that, which I think is a useful way of thinking about things, especially in relation to the question, what are the particular priors that may underlie FND? And I would submit these are not the priors that pertain to the content of my self-modeling or my perception or estimates of the states of the world, but the precision of those, the precision or the context in which I am making those inferences about the states and the parameters. So technically, these would be called hyper priors, because they pertain to hyperparameters, where hyperparameters are parameters of other posterior distributions in a hierarchical generative model. And right at the beginning of the free energy principle, this or introduction of the free energy principle, this was a sort of a foundational story. That if you want to understand a complex system like the brain, you have to bear in mind that there are all sorts of unknowns that are being effectively inferred by the brain that have a separation of timescales, and one, if you like, sort of three-way partition that literally gets into something called a mean field approximation when it comes to writing down the equations for, say, neural dynamics or learning or plasticity, is in terms of things that change very, very quickly. So that would be, for example, things that are encoded by synaptic activity, things that change very, very, very slowly. And these would be the parameters of our models, the contingencies, the laws, the associations that we accrue slowly through repeated experience and experience-dependent plasticity that would come under the rubric of learning and memory, procedural memory, not episodic or declarative. But there is a really important middle ground, and that's slower than the fast fluctuations in the state of the world and the body, but it's changes much more, fluctuates much more quickly than the laws that seem to govern our behavior. And you can think of this as basically in terms of attention and salience, or in terms of the precision that establishes the context, what is important and what is not important in this particular context. Physiologically, this can be read in terms of synaptic efficacy or gain, that's changing not on a millisecond by millisecond level, nor is it changing in terms of long-term potentiation on hours or minutes, or sorry, minutes or hours or days or months, but over sort of the timescales of short-term plasticity, from things like sort of after hyperpolarization effects right through to sort of the minute-by-minute changes in synaptic efficacy that are under neuromodulatory control. So this is, and I think an important aspect of hierarchical inference, but now we're talking about a particular kind of hierarchy where we've got a hierarchy of parameters, each contextualizing the other. So we've got the very slow parameters that contextualize the intermediate parameters, precision parameters, hyperparameters that themselves now contextualize the very fast sensory motor integration and inference about the current state of the world. Mathematically, the key point is that you there is a necessary circular causality here. You have to optimize all of these three kinds of things by physically represented things in the brain in order to do your sort of your active inference or your free energy minimization, which basically means you need to get them all right at the same time. So there is no sort of sequential causal structure here, both in terms of the inference, but also in terms of the neuroanatomical and neurophysiological implementation. And what that translates into is something which, at a very, very coarse grained level of analysis, would be something like the following: that in order for me to estimate the precision and thereby set via various neuromodulatory mechanisms the appropriate synaptic gain, which sets the precision for filtering or assigning precision to various sources of evidence for belief updating that drives synaptic activity, I have to infer the current state of the world, but also I have to have learned the current state of the world, which means that these updates down here, the control of the synaptic efficacy, let's say for simplicity, that mediated by classical ascending neurotransmitter systems, say cholinergic, noradrenergic, or serotonergic, has to be in receipt of contextualizing messages from both from the synaptic activity inferring the current state of the world. So there has to be a cortico-subcortical control of the estimates of the precision that are then reflected back from the subcortex to the cortex, and this could involve thalamic projections that we heard about, that actually implements now the changes in synaptic gain that mediate the fast belief updating, evidence accumulation, Bayesian filtering, whatever you want to call this, that enables inference in the moment of this fast kind. And both of these depend upon optimizing your synaptic efficacy in the long term, that depend upon synaptic activity, obviously through activity-dependent plasticity. But there's also clearly, again, a reciprocal link in the sense that my synaptic activity depends upon the synaptic connection strengths and their fast or contextual fluctuations given the synaptic gain. So this really sort of crude, coarse-grained approach to the kind of functional anatomy entailed by FND sort of leads to many formulations. If I'd got longer, I would have chosen a slightly more informative one, but this is Mark Solmes's formulation. So he just acknowledging that there's this sort of three-way partition of things that have to be kept all mutually informing each other at different time scales in any given brain. And you could argue in any given biotic system. He formulated this using the symbols that Freud brought to the table. But his emphasis really was, at the end of the day, and it currently is, that how we feel or how we experience the world really depends upon the precision that we assign the various sources of evidence, and that he would say that feeling actually comes from precision, which is a really fundamental thing that has to be optimized. And there's a simple mathematical description that was fit for purpose in telling his story. But the point here being, on one, if one just focuses on classical neuromodulators as the key determinant of the precision or the synaptic efficacy that does this balancing, this precision control that controls the sharpness or the curvature or the precision of the minima in the canals in your free energy landscape, then you'll be focusing on the cells of origin of the these ascending neurotransmitter systems. But you would also have to remember that these are driven, and they are driven by cortical dynamics. And then there was another graphic down here that tries to just give an example of the interplay between the cells of origin of the reticular, say, activating system. That's the parlance he likes. And how that fits into the predictive processing based upon both extraceptive and interoceptive cues or and responses in terms of this instance, in terms of autonomic responses and interoceptive inference. So I'm just showing this as one way of thinking about the importance of the interaction between cortex and subcortex and understanding the fundamental pathology, computational pathology that you may be contending with here, that calls for a consideration of not just the targets of the ascending classical neuromodulatory neurotransmitter systems, but also the afferents that are controlling it. The ones that are saying, no, this is where you should be prioritizing and focusing your attention, or personally or subpersonally at the moment, creating this sort of, again, this circular causality, which is a necessary aspect of trying to find those minima on your free energy landscape or your Waddington landscape. So this, just for completeness, these graphics were taken from How and Why Consciousness Arises, some considerations from physics and physiology, which is an early essay by Mark and myself. I'm not quite sure where it was published, but if you can find it, it'll have those graphics in. Good, I don't want to cover that quite. Yeah, just as another, if you like, endorsement of the potential importance of order suggestion, hypnosis, and also possibly the enabling people to mentalize their precision control or their sensory attenuation or subpersonal attentional mechanisms, things like, say, saccadic suppression, and well, you can't mentalize that, but things like saccadic suppression. There is quite a large literature on the key role of precision in underwriting phenomenology and underwriting how we actually experience the world in a propositional way. And this work usually rests upon a particular kind of deep hierarchical architecture where the key aspect of that model of mental action speaks exactly to what both you've been speaking about, but also I've been trying to summarize, which is, in order to control the precision, you actually have to be able to contextualize it. To contextualize it, you have to have a generative model of the context. And if you've got a generative model of the context, and you can infer the context in which you're currently operating, then you can then provide top-down empirical priors on the precisions that then change the belief updating and the attention and sensory attenuation at the lower level, very much along the lines of the original Mark Edwards account. So that again speaks to another kind of deep generative model, but one in which we've got this explicit transaction between beliefs about states of the world and beliefs about the precisions, here denoted by, well, it doesn't really matter, but if you want to get into it, the precisions are denoted by these gammas here, and this kind of argument now has found quite a lot of traction in understanding phenomenology as simply limited to those things to which we can attend to in this context-sensitive way. And if you can't do that, then you are limited to sort of transparent perception as opposed to the kind of opacity that you are feeling this. And that seems to me an interesting perspective on FND, because the subjects know that they're feeling or not feeling something. That's quite a gift, to be able to know you're feeling or not feeling something, as opposed to just experiencing it in a transparent way. Tells you immediately that they must have the most machinery to act upon the belief updating systems that subtend that kind of experience or percept, which again calls upon this ability to control the precision, either to attenuate the precision or to augment it, based upon what you believe about the current context that's contextualizing that precision control. Again, I don't know if it's practically useful, but at least it's entertaining from your perspective, that exactly the same mechanisms that you're contending with and trying to deploy therapeutically are exactly those that people are now thinking about in terms of trying to understand and explain phenomenology in the brain. Interestingly, this community is also deeply committed to an understanding in terms of meditation and meditative practices as ways of getting, I repeat, sort of skilled at deploying these attention. Say breathing meditation would be attending to breath in a way that is not unrelated to the distraction strategies that you were talking about before. But I imagine crucially giving people a procedure that they can implement in order to become volitional, get volitional control over what would normally be subpersonal processes. So I just put that up for entertainment. A similar account. I don't know if you know these colleagues, Jorge Estevez and Francesco, but they have thought about deeply and written a lot about sort of the role of therapeutic touch. And I can't remember precisely, but much of the argument does, and this is something I think we discussed previously with Mark, does rest upon leveraging the hardwired mechanisms that implement the attenuation of sensory precision through that is necessary in order to act. Very briefly, sensory attenuation just refers psychologically to the attenuation of the intensity of a self-produced sensory consequence. In the context of the active inference, this would correspond to a decrease in the precision of any consequence of an intended act that is necessary in order to ignore the evidence that you have not, as at this stage, enacted the intended movement. So if you can't do the sensory attenuation, you can't down modulate or reduce the precision of certain of all sensory afferents that would report the fact that you are not moving, then you can't move. So the ability to engage sensory attenuation, and this usually at a very subpersonal level, is crucial for an embodied interaction with the world, both physiologically in terms of autonomic reflexes, or in terms of striated muscle, willed action, action that is underwritten by priors that reflect the intention to do this or to do that. And if that were to break, then you can clearly see how difficult it would be for any given patient. But if it's working, then you can actually get people, and we heard a nice example with a patient touching their neck to relieve dystonia. A simple explanation of that is that you are now harnessing the fact that you can't tickle yourself. This was a famous application of this. That if you cause your own sensations, you automatically attenuate them. So now you can ignore all of those cues, all that evidence that was previously being assimilated and producing a dystonic response. So that you're sort of harnessing one precision deployment part of the brain to compensate for a failure in another one. Or to put that more simply, you're using sensory attenuation induced by therapeutic, well, in fact, this is not therapeutic touch, this is self-touch, in order to attenuate the precision of certain sensory inputs in order to be able to ignore certain cues that are producing behavior that you would otherwise not be able to preclude. And then that argument was then taken into the realm of physiotherapy and therapeutic touch, and by these authors here that may or may not have some interest. And that brings me to my final point, which is if that kind of argument is correct, what experimental paradigms would you be looking for if you wanted an experimental model of FND? So I'm thinking here really from the point of view not of a clinician trying to phenotype her patients, but more how would you make an experimental model of FND in the lab, and then intervene with hypnosis to test specific mechanistic hypotheses about the efficacy of that intervention in your model of FND. The closest that I've seen is the use of the force matching illusion. And this was pursued, but not for very long. I think Mark actually left the ION and went up to St. George's shortly after this body of work. So I don't think this was ever pursued, but to my mind, it was a really important basic science approach to this, which doesn't address hypnosis. But if you can establish this paradigm and then cross it with hypnosis, I think you you were certainly from the point of view of a sort of basic neuroscience application, be on very solid ground that you could then take into a translational context with possibly patients. But the force matching illusion seems to have a lot to it in terms of the fact that it is a false inference about what you're doing, but it also speaks exactly to or rests upon the functioning sensory attenuation. So if you can produce situations where you can intervene on the sensory attenuation that is reported by the force matching illusion, which is basically this, the basis of this experiment here, where people, well, I, in the interest of time, I won't go through it, but if you wanted to go through it, you can see how you could reproduce this kind of paradigm in normal subjects, but then possibly, I repeat, do it with and without hypnotic suggestion and see what happens, because it's got all the ingredients in. It's got touch in it, it's got sensory attenuation, it's got inference about me moving in a world, and in principle, it has some precedence in the FND literature. So that was my practical suggestion at the end. And now, hopefully, if I can stop sharing, I can stop talking. Thank you very much. Oh, it's really left us. She must have left us. Good. Well, I shall chair then. So yes, please.
Yeah. So no, thank you. It's wonderful listening to you, and a lot of questions answered. And thank you for the last session. I have only one question. I thought I will be someday I'll be asking you. So the belief updation and everything, the prior and everything, we often focus on the cortical dynamics. But if coming from the developmental perspective, our brain is very much parsimonious in using energy. So all this continuous updation, does brain need to redo it every time, or they believe in heuristics? So if we're talking about heuristics, then how part learned behavior, where cerebellum and the thalamocerebellar circuits move in, is important in it. So should we bring in cerebellum into the picture? Because this deep entrenched automatic things, I think cerebellum should play a role, because if it is learned in motor behavior, it has gone beyond the cortical level, the cerebellar level, learned motor behavior. And we have enough evidence from that people cannot remember doing these things. Hippocampus taken out, but the learned motor behavior is there. So I think part of we need to bring in this, because another thing I'm finding, this group of patients, although they know everything, hypnosis is reversing it, they can't get away with it. The movement always comes back. There's a kind of a more habit modification through physiotherapy, more bottom up, which gets effect. So,
yep. Well,
this was my question.
From my point of view, then first of all, heuristics just are priors, and they are priors that have been carefully accumulated and learned, usually during neurodevelopment, but also in an ongoing way in day-to-day life. So yes, you're absolutely right. The most efficient way to do it is the simplest way. So free energy is, or log evidence is equal to accuracy minus complexity. So you're trying to find the simplest heuristics, priors, that will provide the right explanation for everything you're sensing. Part of that developing those the minimum free energy models is exactly as I say, to habitize those things that can be habitized. So if certain things are so conserved, then you don't waste degrees of freedom in terms of re-estimating them, you habitize them. In machine learning, that's known as amortization. So I think it comes from the German word to sort of offset your mortgage or something. Yeah. So if you can habitize or amortize something that you have learned is so conserved and so precise, then you certainly wouldn't you wouldn't bring to the table all the deliberative inference and planning as inference that you would normally do if you had not tried to ride a bike before. And certainly, although it's not part of mainstream cerebellar literature, my favorite hypothesis for the cerebellum is it is amortizing. It's basically learning what the cortex does in or those aspects of cortical dynamics that are conserved time and time again, so that it can now more efficiently provide the answer very quickly, so that you get a more fluent, more automated, more habitized and thermodynamically and metabolically. They all go hand in hand. So yeah, so if your FND is indeed has any sensory motor component that could be amortized by the cerebellum, the cerebellum is going to be a naughty culprit, because it is exactly that that machinery which is keeping you trapped in your very precise, sharp minima. Interestingly, in machine learning, you do get these pathologies, and they're called vanishing gradients. So if you're if you overlearn something in machine learning, if you overfit it, say using a transformer architecture, then you get trapped where all of the gradients you usually use to improve yourself just disappear, and you get just trapped in these sharp minima. So that can happen in the human brain. That may well be a good analogy for the kind of getting trapped, in the way that Quinton was talking about before. And the cerebellum is in a prime position to be a culprit here, because that's its job. Its job is to pick out those things that can be habitized and can be automatized, that occur again and again and again and again, that don't need to be contextualized. So the whole problem, the point of, the beauty of amortization is that it renders processing and belief updating of, again, a sort of non-vernacular sort, as efficient as possible. The problem is it's context insensitive. So as long as I always do this, irrespective of the context, you can amortize it. But if the situation changes, and say I have an amputation or a road traffic, or I get older, or something like that happens, then the context has changed. Then all that amortization is now no longer fit for purpose, and could actually get in the way. And now you have to look at sort of neuro rehab to try and relearn some, and bring back some deliberative cortical control in order to now relearn things. Is that what you had in mind? Quinton, you got your hand.
Yeah. That was all really interesting, Carl, and helpful. Two questions. One, the language of attractor networks for attractors is used in the Rebus paper by Robin Harris and yourself. So one question is, in general, do you find that framework, that conceptual framework of that body of theory useful, or do you prefer alternative terminologies to attractor dynamics? And then the other question, just notwithstanding your comment about the cerebellum, which is really interesting, I just wanted to put forward the idea that actually with functional neurological symptoms, and indeed the mechanisms of suggestion, what we're really talking about are critical changes in relatively upstream levels of the cortical hierarchy, not primary motor cortex and not primary sensory cortices. And so it's a question here about how to conceptualize the effect of priors and downward prediction, how predictions are instantiated. Because it seems to me that probably what is critically happening in a functional motor symptom is that actually a mid-level representation, quotes prior, is being activated in the absence of the sensory information that would normally elicit it. So it's this sort of over precision or over weighting. And so two questions. One is about attractor dynamics and that framework versus alternatives. And the second is about the notion that functional neurological symptoms, in a way, they're a computational pathology of association cortices, relatively mid to high level is where the action is going on. And it's to do with ignoring or discounting evidence that would otherwise constrain cortical processing.
Yep, no, absolutely. The free energy principle certainly likes attractor landscapes, and indeed the physics version of the free energy principle would talk explicitly about attracting sets and attractors when applied to understanding neuronal dynamics, rather it's talking about fast dynamics that underwrite EEGs or slower dynamics that underwrite experience-dependent plasticity. Then those dynamics are just gradient flows on the variational free energy landscape. And the basins of attraction are the attractors, and they usually have a very itinerant form, so they're not sort of usually they're never point attractors, and usually have a very itinerant aspect. But it would be difficult to conceive of a classical version of the free energy principle that wasn't articulated in terms of dynamical systems of this sort, simply because the whole free energy principle starts with a random dynamical system approach. That's its starting point. Give me a random dynamical system, and if it's got an attracting set, then I can tell you a lot about it. If furthermore it has a Markov blanket, I can now tell you a lot about its Bayesian mechanics, and that's where the active inference gets in. So I'm not quite sure what the alternative would be. I mean, you maybe think about information theory, but most of the information theory actually inherits from the dynamics. So you're assuming there's an attracting set in order to get the probability distributions, in order to have the information theory. So they're all intimately related to each other. What alternative did you have in mind?
Well, I suppose what I was just wondering whether you actually had a preferred terminology, because I've read, you've written many papers, I read it, quite a few of them, but attractor dynamic, the terminology of attractors doesn't come up that often, although I did notice it with interest in the Carhart-Harris paper. It might just be the sorts of papers of yours that I'm reading, not the ones that feature that language.
I see. Yeah, you'd have to go to the physics, the free energy principle physics papers, as opposed to applied in neurobiology, I think, to find that. But one of the very first papers on the free energy principle was actually called Free Energy Value and Attractors, I think. That's where it all starts. So right. I'm very comfortable with that kind of language. If you're asking, would I spend my, if I was young, my young career characterizing brains in terms of Hopf bifurcations? No, I would not. We're not talking about deterministic phase transitions. We're talking about stochastic chaos. That's the whole point of working with random dynamical systems. And the random is important because without the random, you don't have inference. You don't have from a probabilistic or probability theoretic approach. Without that, you don't have the information theoretic or Bayesian mechanics. So, notions like bifurcations and hysteresis, they inherit from things like Hopf bifurcations, are really useful intuition builders, but they're not necessarily the mathematical fundaments that we're talking about when we're talking about random dynamical systems. We're talking about stochastic chaos. Having said that, at some scale in terms of population dynamics, you will get, if you like, the re-emergence of these attracting sets and the phase diagrams that look and behave very much like, say, transcriptional bifurcations or Hopf bifurcations, as we see in epilepsy, for example. Anyway, I'm getting distracted by that interesting question, which So I know I agree entirely. I think that's what I was trying to emphasize when I'm talking about the circular causality between the cells of origin of the ascending modulated neurotransmitter systems. And I should say it's not just those. There are all sorts of EI balance and all sorts of sort of synchronous gain mechanisms that affect synaptic efficacy. But it's likely that they are quite important in setting the tone, as it were, the context on the precision. So I was just trying to make the point that these systems have to receive messages from the cortex in order to be told what to do. And of course, what they do is they go back and nuance or moderate the message passing in the cortex. And I think you're absolutely right that the very fact that hypnosis works, because it can be communicated via language, for example, means that we're talking a very, very high level, propositional level of things that clearly get into the game in terms of being able to volitionally get some control over your attentional set, even if you don't know that. And that's just a statement of the fact that you've now been able to excite the cells of origin of the neuromodulatory systems in a particular way that now gives you a particular attentional set. And being able to do that at will, or at least following instruction, is quite remarkable. And it does strike me that certain people may not be able to do that, and they presumably would be non-suggestible, and other people may be very susceptible and very, not gifted, but have that machinery. And I would have thought that meditation is basically trying to increase the very high propositional levels of cortical representations, for example, increase your ability to get in and control the intermediate levels, so that stuff which was previously not under volitional control or not could not be mentalized or was subpersonal now becomes at least now becomes amenable to some kind of volitional contextualization, possibly using other devices, but or possibly with direct communication from afferents from the cortex to the the reticular activating system, as Mark would like to call it. I think that's a bit of a historic term that he likes to call it.
Yeah, if I could just very quickly comment, actually, there's a very interesting property of suggested effects that when you administer a suggestion to somebody who responds to suggestions, they are consciously aware of the content of the suggestion and engage with it. So they might have a sort of some sense of volitionally going along with and engaging, focusing on the content of the suggestion, but the effect happens as though by itself. So there is something about exercising influence through top-down modulation which is not introspectable, but it generates a change in cognition, the outputs of which one does become consciously aware of.
Yes, I didn't know that, but that makes entire sense to me. If I imagine you could hypnotize somebody to suspend saccadic suppression during eye movements and see the optic flow. If I had a concept of that, then I would certainly put and somehow magically you were able to suspend my saccadic suppression. My best explanation was, I did that deliberately, even though of course I couldn't do it deliberately, but that would be the simplest explanation for this conjunction of high and low level beliefs. Yeah.
So I like your idea of modulating attentional set without realizing that you're doing that. I think that's a very useful way of thinking about how suggestion in hypnosis works.
Good. Well, I think we've exhausted ourselves.
So, sorry,
Oh, there you are. I thought you
Yeah.
disappeared. I was about to be you and do all the clapping and everything.
No, I made it back just in time. Can you hear me though?
Yeah.
Okay. No, we had a departmental Wi-Fi shutdown, so I emailed you as well. Of course, you wouldn't have checked your emails during the meeting, but yeah, I'm basically ran back home and made it in time to conclude the meeting.
Thank you.
But I'm hoping that you guys had a great discussion, and I'm excited to catch up on that through the recording. But yes, thank you all so much. Thank you, Abhijit, for the presentation. Can we please just take a moment to applaud him and everyone else for the discussion? Thank you so much. And yeah, thank you, everybody. I will upload the meeting hopefully by the end of the week, and I'll circulate the link as well. And hope you have a great rest of the week. Thank you.
Thank you. Bye.
Bye.
Thank you all.
Bye.
Bye.